Hello and welcome to this critical care teaching video on prone ventilation in intensive care. We'll start by taking a look at the physiological rationale for proning and why turning a patient prone may be of benefit to them. We'll touch on the evidence base for prone ventilation in intensive care. We'll look at whom we should consider turning prone, and then we'll look at the risks of turning patients prone and prone ventilation before we look at how to do it safely. So before we come on to the potential benefits of prone ventilation, let's start by thinking about what's happening in supine mechanical ventilation. The pressure from the ventilator has to push the anterior and lateral chest walls up and out, and it also has to push the diaphragm and the abdominal contents inferiorly. The posterior chest wall is in contact with a reasonably firm surface, usually the bed, and therefore will move very little. The large airways lie predominantly anterior to the majority of lung tissue, and therefore secretions are going to have to try and clear uphill. And the mediastinum, in particular the heart, will compress dorsal lung tissue. When a patient is turned prone, the diaphragm will move in a similar way. The anterior chest wall is now in contact with that firm surface and so is impeded from expanding. The overall effect of this is that chest wall compliance, that is the volume change per unit change in pressure, is reduced. That means that any pressure applied to the respiratory system, and by that I mean the chest wall and the lungs together, will mainly go to expanding the lungs rather than pushing the chest walls out. We've also removed the weight of the mediastinum, the heart, from the dorsal lung, and all of this combined will result in more uniform ventilation and reduced atelectasis. This will also improve ventilation perfusion matching, and in addition, secretions will now be draining downhill. These CT slices through the same patient positioned supine and prone help to demonstrate some of these points. You can see in the patient lying supine, the heart compresses, in particular the left lower lobe, and you can see large areas of collapse and atelectasis towards the posterior aspects of the patient's lung. When the patient is turned prone, you can see the heart now lying against the anterior chest wall and therefore no longer compressing the left lower lobe, and you can see much improved aeration of the dorsal aspects of the lung. Now there has been a little bit of atelectasis affecting the ventral aspects of the lung when the patient is turned prone, but that is far less than the increase in aeration that you see in the dorsal aspects. So why would turning a patient prone be of benefit? Well, if you could improve the amount of lung that is ventilated, you should improve oxygenation, improve CO2 clearance, improve secretion drainage. You will also hopefully reduce overdistension of alveoli and reduce atelectasis, and therefore reduce the risk of ventilator-induced lung injury. So is there any evidence for prone ventilation? Well, for many years we had many studies that demonstrated exactly what we would expect based on the physiology, an improvement in oxygenation when turning a mechanically ventilated patient with severe respiratory failure prone. But we didn't ever see a mortality benefit with these trials. However, subsequent meta-analyses of these studies did indicate that there was probably a mortality benefit to be found from prone ventilation, and in 2013 the PROCEIVA trial reported which did find significant mortality benefit from the early application of prone ventilation in patients with severe acute respiratory distress syndrome. So whom should we be considering turning prone? Well, mechanically ventilated patients with severe ARDS, and by severe ARDS I mean someone with a PF ratio of 150 millimeters of mercury, that's about 20 kilopascals depending on the units you're working on, who is receiving at least 60% oxygen, at least 5 centimeters of water of PEEP, and is optimally ventilated, by which I mean a tidal volume of approximately 6 mils per kilo ideal body weight. We should be turning patients prone for at least 16 consecutive hours before returning them supine. Those indications are straight from the PROCEIVA trial. We should also consider proning patients who've got posterior injuries or posterior surgery, skin flaps, grafting, burns as well. There are a lot of risks with prone ventilation. Just turning somebody prone, we could either obstruct the ET tube or dislodge it completely. We could pull out vascular access or chest or abdominal drains. NG tubes could become dislodged. If support for the patient is not optimally positioned, we could see an increase in intra-abdominal pressure, increase in intracranial pressure. We may see impaired NG feed absorption. You can see elements of transient hypoxia, even hemodynamic instability and arrhythmias. And in turning somebody prone, it's very difficult to do that with all ECG lead monitoring in place, and so we're going to have to lose our monitoring for a period of time. When the patient is prone, they're at risk of edema, in particular affecting the eyes, which could be simple swelling of the conjunctiva through to blindness, and pressure damage over any exposed areas of skin, in particular the forehead, nose and chin and the head, the humeral head, breasts, the anterior superior iliac spine, the male genitals and the knees. In addition to all of those risks, there are some serious contraindications to proning that we must all be aware of. Prone positioning is contraindicated in those with severe hemodynamic instability and cardiac arrhythmias, those with spinal instability, those with extensive polytrauma, in particular where it's affected the pelvis, pregnant patients, in particular those within the second and third trimesters, those with a raised intracranial pressure, recent surgery including sternotomy, tracheal surgery, abdominal surgery, and those with raised intra-abdominal pressure should not be turned prone. So with all those risks and contraindications in mind, how do we do it safely? Well, the first thing we must do is carry out all necessary procedures, such as chest x-rays or changing central lines, prior to positioning our patient prone. Next, we must train our staff, either with volunteers or with mannequins, prior to working with actual patients. We must also ensure that we have adequate padding and pressure area support to ensure that we can support the chest and pelvis, leaving the abdomen free, as well as padding the knees, the ankles, the face and head. As for how to do it and how to unprone somebody safely, I would thoroughly recommend that you watch an absolutely excellent video produced by the ECMO team at Guy's and St Thomas's NHS Foundation Trust. It's available on YouTube. I'll leave a link in the description. It's only 10 minutes long and it will take you through a very, very safe way to turn somebody prone and return them supine. So in this video then, we've looked at the physiological rationale for prone ventilation. We've looked at its evidence base, some of the risks and contraindications, and indeed how to turn somebody prone and return them supine safely. And once again, I would really recommend you watch that video from Guy's and St Thomas's. If you do have any questions about this video though, please leave them down in the comments, and I hope to see you on the next one.